Good morning, good evening, and good afternoon to all the friends, teachers, and all the panelists and delegates for today's webinar. I welcome you on behalf of ACNS YNS committee for this yet another interesting education webinar, which we conduct on every second and fourth Sunday. So for today's webinar, we have Professor Abuzer Gungor as our chief guest speaker, and Dr. Mao Yokota as our YNS speaker. To chair today's session, we have Professor Rabida Shah from India, and Professor Tadashi Watanabe Sensei from Japan, and Professor Ahmad Firzad from Afghanistan. To co-moderate with me, we have Dr. 𝒀𝑵𝒐𝒊𝒄𝒄 from Hong Kong, and Professor Yoko Kato is today's patron, who is the president of ACNS committee. So without any delay, I would request Professor Yoko Kato to say a few opening words, and then I would request Dr. Rabida Shah to chair this session and say a few words for today's webinar. Professor Yoko Kato.
Very much. So we are so happy to welcome the chief guest is Abzu. He is the specialist of especially the anatomical field of neurosurgery. We are very much looking for your lecture. And also, the Mao is my junior. We are very much expecting your lecture. So you learned a lot from Watanabe Sensei. Okay, so please start.
Thank you very much, Prof. So I request Dr. Abida Shah to chair this session and kindly introduce the guest speaker for today's session. Thank you very much.
Thank you, Sachin. Thank you, Professor Kato, for this invitation. And let us have yet another very invigorating webinar for the YNS. I'd like to invite the first speaker, Dr. Abuzer Gungor. He's a good friend of mine. He's been working with Professor 𝒂𝒏. He has a fantastic laboratory and does some amazing anatomical work, as you will see in his presentation. And I invite him now to give his talk on the interhemispheric approach, tips and tricks. Abuzer, you can share your screen. I think he's logged out, Sachin.
Yeah, I think he's logged out. He was saying he was not feeling well. So maybe, maybe in a while when he's joining, maybe we can take the YNS speaker first, and then by the time he'll join, can we do that?
Yeah, we can do that.
Yes.
So I'd like to invite the YNS speaker, Dr. Mao.
He's just joined. He's just joined.
Okay, then let's start with him on. Abuzer?
You are muted, Prof. We can't hear you. Yeah, now we can hear you.
Abuzer, welcome to this meeting, and I would like to invite you now to start your presentation. I already introduced you earlier, and I have said that you have done some amazing anatomical work in your beautiful lab, and now we'd like to see that. Over to you, Abuzer.
Okay. I will present first, or?
Yes, Prof. You can present first.
Present first. Dr. Yokha, yes. Abuzer, you will present first.
Can you see? Yes,
we can see.
Hi, everybody. I will talk about the anterior-interhemispheric approach and some approach just we described. Firstly, I want to thank all of you because you helped us for our earthquake 2 months ago. All countries, Japanese, Indian, from Bangladesh, and from everywhere. I have no conflict of interest. As you know, the lateral surface of the brain has a high eloquent areas. Because of this, we mostly prefer interhemispheric approach. For example, this kind of lesions, you can see it is located in the atrium, and you can see the optic radiation there. If you choose a lateral approach, you will damage the optic radiation, and the patient will have an visual deficit. As you see, it is covered, the lateral surface is covered by the optic radiation. And also you can choose the more superior way. Also the superior longitudinal fascicle can be damaged in this way. But if you prefer the medial approach from posterior intermediate frank one, you can reach atrium only with a minimal damage to the corpus callosum. Just to be published a paper about this approach. We use not only the interhemispheric approach, also we use a transparent occipital fissure to reach this kind of lesions. And also this kind of lesions located in the frontal or parietal region in eloquent areas. As you see, the cortical spinal thorax and the motor area here, it is more risky to reach there transcortically. As you see, the homunculus, and we decided to enter these lesions via interhemispheric transcingulate way, because it is the you can dissect these sulcus, and we describe this approach and use in some cases, as you see, without damage any cortical area, you can reach these kind of lesions via interhemispheric transcingulate sulcus. Because of this, we go to a laboratory and you can see these cingulate sulcus. I always use lateral approach for interhemispheric approach to use gravity. And then I will show some cases, interhemispheric cases for our results. As you see, it is a common pathology to use interhemispheric approach. It is a third ventricular colloid kyst. Everybody perform this kind of surgeries. As I said, I always use a lateral position, and for colloid cyst, I use craniotomy just anterior to the coronal suture. As you see, this is the to avoid damaging these veins, we preserve and dissect from the dura. We always try to preserve all this kind of veins. In these lesions, see, I use a minimal callosal incision. And also, you can use the anterior-interhemispheric approach for thalamic tumors. Sometimes it can be attached, as you see, after reaching seeing the both callosal artery. Just between them, you can choose your entry point. I am using navigation and ultrasound to decide to my entry point. As the after entering the thalamus, you can remove this kind of tumors. And also the different case, the same position. And our incision, and you can see the corner suture. Sometimes we start just under it. I always put craniotomy just above the suprasagital sinus. And also, as you see, there are a lot of attachments in these patients. It was difficult to reach the callosal area. And I use navigation to decide to my entry point. And also inside the ventricle, to decide my entry point, I will check also nerve monitorization and the nerve navigation. After reaching the tumor, you can remove with using navigation and the nerve monitorization. And this is a 10 years old female patients with globus pallidus tumor. As always, I use the craniotomy, and I use a 𝒂𝒐𝒒, the cartonate with 𝒂𝒐𝒒 sealant. Using navigation to check my entry point. And after reaching the tumor, without using a bipolar coagulation, because as you see in these patients, because of the bipolar arterial injury occurred. Fortunately, it stopped. And this is the postoperative view. And also, you can use this approach for third ventricular craniopharyngioma, as like in this case. As you see, this is the typical craniopharyngioma. We will remove via foramen Monroe. We removed all the tumor, but after the tumor, patient had a ischemia, but later it recovered, and without the deficit, we can charge her. And you see, this is the control diffusion MRS. And also, you can use this approach for distal anterocerebral artery aneurysms. After proximal control, you can clip. Sometimes it's needed to open the ventricle. And also, I want to show a case, a corpus callosum carcinoma and a cyst because of this carcinoma. As usually, the patient has a small carcinoma, but the continuous hemorrhage. She had a big cyst. The same position. And after reaching the carcinoma, remove. And the patient didn't have a foramen magnum. It's closed. Because of this, we opened foramen magnum and did a third ventriculostomy via 𝒂𝒐𝒻. And lastly, for medial located AVMs, you can use 𝒂𝒓𝒐𝒃 approach. We are lucky only it is supplies from only callosal artery. We did the same craniotomy and open the 𝒂𝒓𝒃 fissure. And so AVM and use the Doppler ultrasonography to see its location. And we put temporary clip, which is, we think the supply. And check again via Doppler ultrasound. Then we start to remove. This is the typical AVM surgery after this part. This is the postoperative MRI. And this is the case today I want to show. Thank you for listening.
Thank you, Dr. Abujar, for that wonderful presentation and showing some nuances of the intrahemispheric approach. I would like to first invite Professor Kato for her comments.
Thank you very much. So even the very narrow the field, so you can treat almost all the pathologies, especially the AVM. So do you have any difficulty through such a small the field? Can you hear?
I think he has just gone somewhere.
Okay.
I don't see him there. He's back.
I'm sorry, I just wrote it. I am not good position.
Okay, no problem. No problem, Abuzar.
Is it possible?
Well, thank you so much. So such a wonderful, the huge experiences through the interhemispheric approach. So especially the vascular lesion, the ABM. So do you have any difficulties such as small feeders, small surgical field? Can you hear?
Yes. What did you ask about small craniotomy?
Yes, as for the ABM. So
Yes,
do you
yes.
encounter some the difficulty?
No, because it has one supplier and it is difficult to handle. Because of this, I use a small craniotomy.
Okay, so you usually use some wet clip or?
Yes, I use a temporary clip to check the AVM, then start the EMO.
Okay. So most of is it incidental or the rupture one?
Also ruptured one. It's not important. Also incidental one.
So after some the huge studies, so do you reduce the treatments of the unruptured ABM?
Sorry, can I?
So what's frequent to treat of the ABM by surgically?
Surgical. I always choose surgery, not embolization tube or just embolization, and I don't send patients the gamma knife. Most of the patients are surgery. In my clinic, I think 8% of the incidental women perform surgery.
Okay, because once I heard the Google Trill that he hates to do the embolization preoperatively.
Yes, I don't use probe embolization because it can be difficult to manipulate the AVM after embolization, and also embolization has also complications.
Okay. Okay, thanks. Thank you very much for congratulations for a nice lecture.
Thank you.
Professor Takizawa, would you like to make a few comments?
Okay, thank you for nice presentation and beautiful videos. He mentioned about the bridging vein during his presentation. Okay, in terms of approach route depend on the running course of the bridging vein. Also, we should preserve the bridging vein. So how every case preserve the bridging vein? Or?
No, every case I always preserve bridging veins. As you see, sometimes I use 1.5 centimeter dual incision to preserve these veins. I try to preserve and dissect, but if it's not possible, I use small dual incision.
Okay, understand. One more. Do you use a ventricular drainage?
No,
never use.
No, never. In my ventricular cases, I never use ventricular drainage, and none of my patients required extraventricular drainage after operation, but also maybe 1 month later, patients can require a VP shunt, but it is very rare.
You take off the CSF from the interhemispheric fissure gradually.
Yes. Yes.
Okay, thank you.
Thank you, Dr. Takizawa. Can I invite now Professor Watanabe for a few comments?
Okay, hi. Thank you for a beautiful presentation for various kind of pathology using an interhemispheric approach. And one thing I want to ask you is, have you ever considered using an endoscope for interhemispheric approach?
Yes. But interhemispheric approach for control the pathology, I didn't show, I'm sorry, but I use to control all interventricular cases, not pure endoscopic cases, but endoscopy assistance. I am using endoscope to check the surgical area.
Okay, like the first case you showed me, the tumor is nearby the motor cortex and facing to the falx. So maybe you have to retract the brain, which contains the motor cortex.
No.
So maybe the 30-degree endoscope will help you to look around the corner. So actually, I use endoscope in such a case. So I asked you about the use of endoscope.
Yes, I am using endoscope, and I am performing endoscope assisted surgeries. But this case, it didn't require retracting the brain because I use gravity with this position. Without retraction, you can do this kind of surgeries.
Okay, thank you.
Thank you, Dr. Watanabe. We have our discussions. Dr. Alexander, are you there?
Yes, hello, I'm here. I'm sorry I relied on my mobile internet, but only now could join it. So I'm sorry I missed the election. So I'm sorry I cannot comment. I've just joined your webinar just now, as I got access to mobile internet. So I'm sorry So I'm with you, but I'm only listening.
No problem.
Sorry.
We have some young fellows of Professor Kato. So I would like to invite Dr. Joe for some questions or comments if he has any.
Hi, thank you, Professor Videsha. Great lecture. Yeah, I was wondering if there would be any tips for us on how you preserve the bridging veins, and which people have said that the anterior 1/3 bridging veins are actually safe to sacrifice. Do you think that's the case, or should we try to protect all of them? Thank you.
Yeah, I always try to preserve all bridging veins, because in every case, not in interhemispheric case, also for supracerebellar cases, I always use these bridging veins, because you couldn't know what will happen. Everybody says it's safe, but somebody have some complication after sacrificing these bridging veins. Because of this, I always preserve these veins, because as you say, I use a small dual incision sometimes if they didn't allow you. I try to dissect from the dura, but it is not possible to dissect. I use small dual incision. And preoperatively, I use MR venography to describe our dual incision. And also Doppler ultrasonography to describe the location of these veins.
Okay, thank you very much.
Okay, so we have a few questions. Dr. Atik, you have raised your hand.
Thank you, Professor, for your nice presentation. It was a great memory we meet in Bangladesh 2 months back. Can you, hopefully you can remember those memory. And now I am doing my fellowship under Professor Yuka Kato Sensei in Fujita Health university, and it is also a wonderful time for us. My question is, what is the size of your craniotomy during intrahemispheric approach, like when you perform to remove the colloid cyst? And my second question is, here we are using a software that is AMIRA software, where there is a fusion of CTA, CTV, MR perfusion, and DSA, which helps to locate the breathing vein, and it helps to choose the site of craniotomy. Do you use this software, or how can we use this software in our center also? And my third question is, in spite of being all care, sometimes it becomes very difficult to preserve all the vein. In that case, sometimes it need to work in between two veins, or sometimes need to give dural incision more. So is there any option to sacrifice a small vein when there is that much difficulty to go to intrahemispheric approach? And my last comment is, for young neurosurgeons, do you suggest to use gravity-assisted approach, which is a little bit difficult for anatomic orientation for the beginners? In that case, neutral position is...
I think if they start in this with this position, it can be easy. It is my style, but also you can use supine position. But if you start for young surgeon, if you start with this position, it is easy, because using gravity without retraction can protect all cortical tissue. And also, you said the craniotomy, most of the colloid cysts, I use 3 centimeter or craniotomy for this kind of lesions. It came in out. And did you ask any question more?
And my another question was, sometimes it is very difficult to preserve all the veins. In that case, sometimes we need to work in between two veins. And in my center, I see some of the neurosurgeons sacrifice 1 or 2 small breathing.
Sometimes I use 2 dual incisions.
Yeah.
And in one hand aspirator and one hand bipolar, without damaging the veins between them. I can perform operation. I never sacrifice any veins.
That's good. Thank you. Thank you.
I think.
Thank you, Dr. Atiq. Dr. Ben, you have a question?
Yes. First of all, I would like to thank Professor Busa for your great lecture, and thank you so much for sharing your experience to the young neurosurgeon, even though you are not feeling well. We really appreciate that, and thank you so much, and also for your great lectures. So my question is about, do you have any experience with a contralateral intrahemispheric approach, that you approach the lesion from an outside by cutting the fox, and how would you choose ipsilateral or contralateral? My second question is about, I saw that in your presentation you have some really nice DTI pictures. So do you routinely do DTIs for intrinsic lesion for when you using the intrahemispheric approach? Thank you so much.
What was your first question?
It's about, do you have experience in using the contralateral?
Yes, contralateral approach. I use most of the thalamic cases. I use the right-sided craniotomy to preserve the dominant hemisphere. But for medially located lesions, I always use ipsilateral approach, but it depends on your preferences. Also, you can use a contralateral approach and cut the falx and reach most of lesions.
I see. So how about the DTI? Do you routinely do the DTI for intrinsic lesion when you're using the endoscopic approach?
For intrinsic lesions, I always use tractography, and the lesions must be located just lateral to medial to the corticospinal tract. If the lesions located lateral to the corticospinal tract, you must choose the approach in lateral way.
Thank you so much, Professor. Take care.
Thank you, Ben. Dr. Karimov has a question. Abuzar, are you okay to answer?
Yes, I am.
Okay. Dr. Karimov?
Thank you, Professor. Can you hear me, Professor?
Yes, yes, we can hear you.
Thank you for lecture, Professor. And I was just interested in the VP shunt after operation, and as our professor mentioned about it. And I wanted to just ask how frequently patients underwent this procedure after operations.
In which kind of lesions? It is very rare, because for thalamic cases, I also perform a third ventriculostomy via 𝑡ℎ𝑒 because of it is very rare for colloid cyst. I have never used post-operative VP shunt, and most of the ventricular lesions. Sometimes for thalamic tumors, for recurrence, you need a VP shunt, but very rare, because I perform in the operation a third ventriculostomy.
And is it somehow correlates with intraoperative bleeding?
I use some hemostatic agent like Surgicel, and for thalamic tumors and globus pallidus tumors, it is I never use bipolar coagulation, and I wait, and sometimes maybe you can use maybe transamine, intravenous transamine, and wait with elevation.
Oh, thank you so much, Professor. It was very great honor.
Thank you very much.
Dr. Hiba, do you want to make some comments?
Actually, I think Professor Abuzar is actually very sick, and I don't want to bother with many questions. I wanted to ask about the EVD, and he already answered, and also the use of endoscope. The third thing is actually the dissociation syndrome, especially in the thalamic lesion or the midline middle colozotomy, if this is the case. And I hope you get well soon, Professor. I think having migraine is a bit challenging.
I am very sorry about this condition.
No. Thank you for actually answering all our questions.
Thank you very much. Can I leave, Abida?
Yes, Abuzar, you can leave.
Professor
𝒏𝒂𝒏, can he leave?
Yes, thanks so much. Well, please take care.
Yes.
Thank
you,
very much.
Abuzar.
So excellent the lecture. Thank you so much.
Thank you. Thank you.
Okay, so Sachin, should we go ahead?
You're muted.
Yeah, unmuted.
Okay, I'm sorry. So we'll go ahead with our next YNS talk. So could you please introduce our next speaker and her the title of presentation?
Yeah, so I think we will now invite Dr. Mao Yukata, who is from the department of Professor Kato at Fujita Health University, and she's going to talk to us about exoscope. So we are very happy to hear from her. Sachin, I might have to leave in 15 minutes, so then you take over.
Sure, I'll take over. Thank you. Thank you for joining and sharing. Thank you.
Thank you.
So,
Thank you.
Abida, thank you very much. So the Mao is from Aichi Medical University, not Fushida.
Yes.
Okay.
Yes. Okay. So I would request Mao Sensei to please share her screen and start the presentation.
Okay, thank you for Professor Sherd and Sachin. So okay. Can you show me my presentation?
Yes, we can see it and we can hear you clearly. Please go.
Okay, thank you. I'm a resident in my 5th years of neurosurgery. So in this year, I'm going to take board exam. So first, neurosurgical training in exoscopic surgery. Thank you for giving me an opportunity for presentation. Today, I am going to presentation how exoscopic surgery can be useful in training. First of all, let me tell you what an exoscope is. It's about history of exoscope. The first use of the word exoscope was in 1994. In 2006, Dr. 𝑣𝑖𝒂𝒐 also mentions exoscope. Next, 𝑣𝑖𝒂𝒻, which is still in use today, was developed in 2008, and 2 years later, in 2010, it was used in actual surgery. In the 2010s, many reports of operation using exoscope began to appear, but at that time, it was still 2D. Around 2017, 𝑣𝒂𝒻 became 3D and started wearing glasses to perform the surgery. Another major change was the introduction of orb eye by the Japanese manufacturer Olympus in the 2020s. Some exoscopes are derived from the endoscopes, while others are closer to microscopes. 𝑣𝒂𝒻 is more endoscopic and KINEBO is more microscopic. From there, 3D ones, robotic ones, and some things are gradually being developed. And the exoscope was introduced in our hospital in September 2019. Brain tumor surgery, our department has shifted using exoscope and endoscope instead of microscope in almost all cases. I joined the Department of Neurosurgery in April 2019 and has learned most of my experience on exoscopic neurosurgery. In this environment, I have noticed the advantage of the education aspect of exoscopes, which I will discuss in this presentation. So we use orb eye by Olympus and 𝑣𝒂𝒻 3D by Storz. I will tell you about the future of exoscope. First, the small size of the scope body allows both the surgeon and the assistant to easily reach the surgical field. The photo on the right side shows the free visual axis of the exoscope, also make it easy to look horizontally or look up, which has been difficult with microscope. With microscope, the view of assistant differs from that of the surgeon, and assistant view is not good 3D sensitivity. In contrast, with exoscope, we can share the same field of view and 3D view, making it easy as to understand orientation. We can quickly switch to macro surgery. Switching to endoscopy is smooth because the exoscope, like the endoscope, is ahead of surgery, performed by looking at a monitor. Another major feature, the camera can be operated by assistant using a remote control over the body instead of using a foot switch, which is done by the surgeon in microsurgery. So in our exoscopic surgery, the role of the scopist is required as a cameraman who is responsible for moving the surgical field and zooming in and out of the surgical field. For this reason, our surgeons are divided into 3 roles: surgeons, assistant, and scopist. In the case of supratentorial tumors, the basic style is to have 3 people, surgeon, scopist, and assistant, stand side by side on the patient head side, and 2 monitors on the caudal side. Next, in the lateral suboccipital approach, the patient can be positioned in the supine position with a shoulder raised up the pillow. In this case, 3 people stand side by side. This is a layout of operating room with BTOM. Multiple monitors are lined up. When using BTOM, the endoscope and exoscope are interchanged on the uni-arm. Next, surgery for epidermolysis cyst of the left CP angle. Patient is supine position. And macro operation until craniotomy. And we use exoscope from dural incision. We operate while watching the same monitor. The assistant is positioning as needed. The assistant can easily access the surgical field. And switching to endoscopes is smooth because the same monitor. And this is a floor standing pneumatic holder called uni-arm. This scope holder can hold both of exoscope and endoscope. Scopist controls the camera in the same way after they change the endoscopic surgery. Because the endoscope enter into the skull, more delicate camera work is required. The scopist is always touching the shaft of the endoscope to achieve delicate movement. Like this. Changing 30-degree endoscope. And finished. Closing is done by junior resident with guidance from senior and using both of exoscope and macro view. Sorry. How about OBI? This is a layout of the operation room with OBI. Uni-arm for endoscope is on standby. This is a movie. Scopists operate by sitting down and using the camera body and the foot switch. The body is 1 size larger than BTOM, but image quality is same as a microscope. And OBI also make it easy to switch to endoscope. Then I will talk about how exoscopic surgery can be useful for training. If the trainee is the surgeon position, the instructive assistant and scopist will stand on both sides. I can receive guidance by adjusting the position and the visual axis and guiding the progress of the surgery. Instructor can easily provide guidance because the because they are looking at the same monitor. Another advantage is that the head is small. The hand of the assistant are easily accessible. So in some cases, 2 hands are inserted from each side so that 6th hand can be seen in the surgical field. The surgeon can safely perform the surgery with camera work and support from the assistant, even if the surgeon's experience is limited. This movie is glioma surgery. We used 𝑣𝒂𝒐𝒄 3D. Trainee is performing surgery in this movie. The supervising physician is actively assistant. Scopist is guiding me in the direction in which the surgical should proceed. Next one is bypass. The scopist adjusts smoothing in and out, which are important in bypass surgery according to the surgeon progress. This movie is from eye. Image quality is good enough for bypass surgery. Next, how about trainee is scopist? The scopist is truly a second surgeon. The scopist is responsible for the movement of the exoscope, including zooming in and out, focusing, and shifting the viewpoint, which is a surgeon responsibility in surgical procedures. The scopist controls all aspects of the camera and plays a role of a part of a surgeon. Therefore, when a trainee is a scopist, one must be able to understand the strategy of the surgeon, even if the scopist is not the surgeon. The trainee feels as if experiencing the surgery as a surgeon. Naturally, if the trainee is inexperienced, there are many cases in which surgeon's intentions are not met or a delay occur, and in such cases, one received verbal guidance from the surgeon who is also instructor. This is feedback for learning surgical know-how, and the scopist's experience is very important as training. It's an experience of active participation in surgery, as I am able to grasp the whole picture of the surgery more calmly than when I was surgeon myself. For me, who is always itching to perform surgery, being a scopist is especially meaningful because it gives me a strong sense of being a second surgeon and allows me to watch and learn the techniques. Next, trainee is assistant. Trainee often join as an assistant, and this position is used in complex cases. Also, I join as assistant. I always see the same screen as a surgeon and followed operation. Through the exoscopic itself is in the operative field, it is also possible to look directly at the operative field, allowing the surgeon to see both the overall view and magnified local view. The assistant adjusts them standing position as necessary to support the surgery from a direction that is easy to insert the instrument. During joint surgery with other department, the body is smaller than that of the microscope, making it easier to operate with each other. And small footprint accessibility. We can share information on each other's surgical field by 2-screen display. Deepened understanding of anatomy and orientation. Just because the exoscope is outside the operative field doesn't mean that it is completely safe. If the focal distance may be shorter than necessary, it may hit the surgeon's tool, and if the surgeon's tools are pushed by the exoscope, this may naturally lead to accident. And some cases, a little are clamped in one horizontal row as the photo on the right side. One more thing, if the assistant stands in a position that surround the surgical field with the surgeon, hand-eye coordination can be lost and require some getting used to. Conclusion. In heads-up surgery, we can run surgery from 3 roles: surgeon, scopist, assistant. The scopist can be second surgeon, which is important the progress of the operation. Trainee can easily understand the orientation and easily provide guidance because they are looking at the same monitor. Thank you for your attention.
Thank
you,
you.
Mao.
Thank you very
Thank you.
Thank you very much, Dr. Mao, for that excellent presentation. Professor Abhilash has left. I would request your mentor, Tadashi Watanabe Sensei, to make some comment about the presentation, and would request you to add some more points for especially for the young neurosurgeons. Professor Watanabe Sensei.
Yes, as she told, I agree. The exoscope must be a good item for education, especially for the scopist. The role of scopist is interesting. In microsurgery, the role of scopist and the surgeon is get together, but we can divide into 2 roles. And they can experience the part of the surgery, and they think they are really participating into the surgery. So, I mean, in terms of experience, they can get more experience than microscopic system. Yes.
Thank you very much, Prof. So, yes, I can see Dr. Atiq Islam from Bangladesh has a hand raised. Please go ahead, Dr. Atiq.
Okay. Thank you, Dr. Mao, for your nice presentation. Basically, during our stay in Fujita, we had an opportunity to meet Professor Watanabe Sensei. It was a very nice experience for us. And basically, I have special interest in endoscopic and exoscopic surgery. And my question is to Professor Watanabe Sensei that basically exoscopic surgery is keyhole surgery. And craniotomy size is also very less. And it is very effective in the era of minimal invasive surgery. My question is, what are the tips for YNS when you do this type of craniotomy and to reach to site of tumor, particularly in anterior skull base and medial cranial fossa, how to manipulate the brain to reach the tumor? And my second question is there any size limit which cannot be done by exoscopic surgery in anterior skull base and medial skull base approach?
Okay.
Can you hear?
Okay. Your question is size of a craniotomy. Actually,
No.
our style is, maybe I understand your question. Our style is combined exoscopic and endoscopic. I tell you why our craniotomy is small, and that is because we use the endoscope. So we can make it small, and for a young neurosurgeon, actually exoscope is like a microscope. So you don't have to make it small from the first experience. So I mean, by experiencing the cases, you can gradually make it small. Maybe finally you can find the appropriate size of craniotomy using an endoscope. And actually, but if the craniotomy is less than 2 centimeters, it may be uncomfortable for us, even me. So because we need a space for the endoscope, and we need a space for manipulation. So I recommend the 2.5 or 3 centimeters for keyhole. And if the craniotomy is the bigger than 5-6 centimeters, actually it is uncomfortable when we use the endoscope, because I always fix the shaft of the endoscope at the edge of the craniotomy to stabilize the endoscope. So if the craniotomy is too big, it may be uncomfortable. So maybe appropriate size is 2.5, 3 centimeters, and maybe 4 centimeters may be fine. Just like that, okay?
So what Watanabe-sensei?
Yes.
Thank you very much for your very nice comment for the Mao presentation. Just I want to ask, because the Mao sensei is just 5 or 6 years after graduation.
Yeah.
So the chart from the beginning, under the microscope or under the endoscope, because some the surgical field is a bit different from under the microscope and under the endoscope. So what is your comment, please? I want to ask both of you.
Okay, thank you for question. I told I might join Department of Neurosurgery in 2019 April, and Dr. Watanabe and my exoscope come September. So I learned of microscope and endoscope is only a few months. So, but in our hospital, emergency case about clipping or bypass, we use microscope because we think we can use microscope.
Okay, so you trained under the both.
Yes, yes, exactly. Actually, they are using both microscope and exoscope. So, yeah, they can use microscope also.
Thank you very much.
Thank you.
Congratulations, wonderful talk. Thanks so much.
Thank you.
So I can see a hand raised by Dr. Bakuri John Karimov. Dr. Karimov, kindly introduce yourself and ask your comment.
Thank you so much, Prof. Mao Sensei, for your lecture. I am a young neurosurgeon from Uzbekistan, currently doing a fellowship in Fujita University under the supervision of Professor Kato. And I just wanted to ask how you began your endoscopic training in a first steps, like you have showed your pictures about when you were as a surgeon, as an assistant surgeon, but in the beginning, how you trained.
Thank you for questions. Thank you for your question. So, beginning is first years in neurosurgery. We can do operation, and training is we join the operation as if I am assistant or scopist, and we look Dr. Watanabe's scopist view. We look always every operation we look, and we image if I'm assistant, if I'm scopist, we image. I'm imaging every time in operation. So yes.
So I wanted to ask, do you have in your university some kind of training laboratory for endoscope or
training lab is no,
Actually, no,
only
no,
microscope.
But actually, for trainee, for young neurosurgeon, hematoma removal is the first surgery to do to get used to the endoscope, and then they assist the endonasal surgery and also keyhole surgery, and I think it is important to get used to it. So every time you prepare the endoscope and frequently we use, so they learn how to use it and what is important and what is safe. They learn. So the important thing is prepare endoscope every time. Okay. For education.
Thank you so much, Professor. Thank you so much, Professor.
Thank you. Thank you very much, Dr. Karimo. I request Dr. Dilshad Muhammad Aliyev, who is also a young neurosurgeon from Uzbekistan, good friend of mine with a huge interest in endoscope. Please kindly make some comments or some doubt. Dr. Dilshad.
Good evening, everybody. Thank you so much for nice presentation, Dr. Mao, and I personally know Dr. Watanabe very well. He's a great mentor of us in teaching endoscopy and all techniques in other fields of neurosurgery as well. So I'm wondering, because we don't have any experience of exoscope in my country, and still we are watching these beautiful surgeries here, do you think exoscope can fully replace the role of a microscope and can be done surgeries with exoscope combined with endoscope with the all corners of the skull base or intraventricular lesions? The question is addressed to both of you.
Thank you for your question. I think we can exoscope can replace microscope because 𝑏𝒂𝒐 view is not clear than microscope, but to overall is same quality as microscope, I think. So we can do, yeah, at KINEBO, yes, as KINEBO, yes, I think.
Okay, very nice.
Yes, yes, my opinion is maybe in the near future the exoscope replace the microscope, because as she told, quality of the image is good enough even now. So and also the many other function will be we can get more and more, and fusion with some digital information is much easier with the exoscope for at the monitor. It's a digital image and not an optical image, so it may be easy to fuse and make a fusion with like navigation information or some tractography or something, maybe in the near future. And also the company, the manufacturer, they are shifting to make the exoscope because the cost of making the product is much easier. So, so maybe gradually it will be changing. And also using endoscope is very important to minimize the scar, the wound, and also we can look around the corner. So it has a very strong advantage. So we should use endoscope in every cases. That is my opinion.
The perspective of modern neurosurgery is going to be this is going to be a perspective of modern neurosurgery, minimally invasive.
Yeah.
Thank you.
Thank you.
Thank you.
Thank you, Dr. Dilshad. See one more hand raised by Dr. Yusra from Pakistan. Dr. Yusra, please introduce yourself and ask your question.
Hello, hi, can you hear me? Hello.
Yes, we can hear you.
Okay, so I'm one of the young neurosurgeon from Pakistan, currently getting trained in UK. So I just wanted to ask, since exoscope looks like it's replacing endoscope, so is it necessary that we always have endoscope prepared while we are performing the exoscopic surgery? And is it important for a trainee to understand how to function endoscope before moving on to exoscope? That's my question. Thank you.
So you're asking Watanabe Sensei or Mao Sensei?
I'm asking if for the trainee, is it important to understand how to work with endoscope before moving on
Yes,
to
we understand. To whom you can?
For me?
For Dr. Mao or Dr. Watanabe?
For Mao. Yeah.
Mao.
Sorry.
Yeah.
Thank you
Sorry.
for your question. So we learned always look every time Dr. Watanabe's assist moving and camera work. We look always. So next time we tried. I joined the surgery operation and do while the senior doctor guiding for me from the verbal advice. So change the senior moving. We run always actually operation every time. Okay. Well,
Yeah. Yeah. Thank you.
okay.
In my opinion, young neurosurgeons should get used to use the endoscope, because it's a little bit different from surgery with microscope and surgery with endoscope. And actually, exoscope is similar as a microsurgery. So we can say it's a same manipulation, but endoscopic manipulation is a little bit different. So young neurosurgeon, in my opinion, young neurosurgeon should get used to use an endoscope.
And from my understanding, it looks like we need to have endoscope prepared when performing an exoscopic surgery. Is that correct?
Watanabe Sensei, maybe you want to answer that. Do we need to have endoscope prepared or ready when we're performing endoscope surgery?
Yeah. Especially for tumors, like skull-base tumors and intraventricular tumors. And actually, in most of the case, we use endoscope at the latter part of the surgery. So, but the length of the time it's according to the case. But in every case, there is something to do with endoscope. So it may be important to put the endoscope into the surgical field. You can see a different view, different from exoscopic view, and you can learn. And even if you removed all the tumor, maybe there remains some if you look around the corner. So yeah. So I would like you to experience the world of endoscope. Okay.
Thank you. That was helpful. Thank you.
Alexander? Alexander?
Professor Alexander Wozniak, are you there?
Yes, hello. Can you hear me?
Yes.
Yes, we can hear you. Do you have any comments or any questions for Professor Alexander?
Thank you, thank you. I have a very small experience with the exoscope. I have not it in my OR, but I had it for testing from Olympus for 1 month. So I did some surgeries. I did transsphenoidal, I did skull base surgery. So it took me maybe a couple of minutes to switch from micro to exo. It's very easy. So I actually agree with Dr. Watanabe, he's expert in all the kinds of these surgeries. It's actually the same micro, but more convenient for a neurosurgeon because you are sitting relaxed, you are watching the screen, and you do not need to adaptate your head and your neck to the microscope. In my experience, there was some maybe inconvenience for assistant because they were not trained before for these surgeries. It may be a little bit inconvenient for them, but I think it's with time, with gaining more experience, we can train it at the assistant. We will work better. And I didn't use Scopist at all. I did everything by myself. I didn't feel no inconveniences with this. I just replaced the camera and it was enough. So in my experience, so I completely agree. I will try to get this tool for my department in the nearest time. So now I'm discussing it with my administration. So maybe I will get, I will have it in my OR because it's really a great tool. It's a really great tool, and I recommend to have it for everybody in the OR. So this is my opinion. Thank you.
Thank you, Alexander. So maybe you can send your YNS to the Watanabe Sensei department maybe in the future. Still we are waiting for your fellow.
Yes, I told you there is some problems. Okay, we will discuss it a little bit later. So
also you can send your fellow to Watanabe Sensei department.
Okay. Thank you.
Thank you, Prof. Alexander. So, do we have any more questions? Dr. Ben? Dr. Ben works with Mark Kelvin, and he is a good endonasal endoscopic surgeon. So, Ben, do you have any question for Mao Sensei, or have you have any experience of endoscope?
Yes, and I would like to congratulate Dr. Mao and for her great sharing on using the exoscope. Actually, I personally started using exoscope as well. So started with some simple cases for some meningioma. I think the experience is that we can firstly the trainee can actually appreciate the detailed anatomy for the especially the assistant can actually appreciate the anatomy better compared to using the naked eyes when we are doing the surgery. They can appreciate how we could do the microscopic dissection. And also, I think there is something not mentioned in the lecture is about those spine cases. For example, doing the olive cases, that many neurosurgeons would started to use exoscope. Because traditionally with that device, you might not use microscope for this. Then the other trainee cannot learn the surgeon's technique. For example, for those with difficult position. So I think first of all, it's very good for learning. The second is that we have talked about the training for young neurosurgery, for young neurosurgeons using the exoscope. I personally attend some workshop organized by plastic and ENT colleagues who are also using exoscope, because there is increasing use by other specialties as well. So we are practicing on those microvascular anastomosis. So I think this one of the that I would say cadaveric workshop would be very useful for the young neurosurgeons to train using the exoscope. I think that's the opinion, and I also want to congratulate your team for the very great experience. And I hope you can gather more and more experience and share some tips for the young neurosurgeons on how to train using the exoscope. And sorry, I just want to mention about the last thing is about as mentioned in your presentation, the surgical setup is very important, I think, because you have a arm for controlling the exoscope. So that might obscure or it could obstruct the surgeon's hands to approach the surgical fields. I think it's important that we need to adapt ourselves in the surgical setting, that we need to put the right instrument at the right place in order to facilitate your surgery. Yes.
Thank you. Thank you very much, Dr. Ben.
Maybe Watanabe Sensei, do you have some such kind of the hands-on workshop at the 𝑗-MEDICAL every year, or?
Yes, actually we have a cadaver workshop once a year in July, but only 1 or 2 exoscope we can use. So the participants have to share the exoscope, mostly using microscope, but they can experience that what the exoscope is. Yeah.
So thank you, Watanabe Sensei. Please share if there is any workshop that held at your place. I would be very interested to join, and really congratulations. And sorry, I have an emergency operation that I have to leave earlier. And thank you so much for your great sharing. And see you later. I may leave earlier. Bye, Surgeon, and also Professor Kato. See you later on.
Thank you, Ben, for actively participating. All the best for your surgery. Dr. Karimo, you have hand raised again. Do you have any comments?
Yeah, I have a small question. Just I have seen in the presentation that there was a slide about bypass surgery, and my question is, are you planning or have you tried yet using exoscope for bypass surgery even?
We are doing a bypass by exoscope. Or why we use?
You are using already, right?
Yeah, of course.
Yeah. Okay. Thank you so much.
Thank you.
Thank you very much. So, are there any other comments or any doubts from anybody? So,
Mao Sensei is the same age of Dr. Tanaka Sensei. She's going to have a board exam this summer.
Riki Tanaka.
That's wishes.
Okay.
So you can join the upcoming May 5, 6. We have some workshop.
I join. I will join. Thank you.
Yes.
Thank you.
Thank you. Thank you very much, Mao Sensei, and all the best.
Eva Sensei, can you encourage her, please? That she is maybe your junior, please.
Yes, I already have her email. We will get in touch together.
Okay.
Thank you for your great presentation, Mao.
Thank you.
And also, Japanese Prime Minister Kishida, Mr. Kishida, that he visited the Cairo, Egypt, yesterday.
Yes.
And the Africa, especially especially Egypt is very much advanced. It's a very promising country in Africa, I think. Congratulations.
Thank you so much.
all.
Thank you.
Okay.
We're waiting for you all there.
Yeah.
Thank you so much.
Thank you.
Thank you. Thank you very much. So if there are no question or comment, I have very small comment to make. I was thinking whether I should tell or not, but it's very stupid story, but I tell. In my village, it's a small city, we have an old microscope. But now recently, microscope eyepiece not working, but the camera is working. So we use microscope, but we look at the TV and
As
we
an
operate.
exoscope.
So I'm like partly training on the exoscope. So maybe in future I'll buy an exoscope. So maybe sometimes if you don't have exoscope, you can do that. It can be an alternative training for you like that. Am I right, Watanabe Sensei? Can we do like that?
Yes, exactly. You are right.
Okay.
It's a great tip for developing countries.
Yeah. So thank you. So we had a wonderful webinar today about exoscope surgery, interhemispheric approach, and endoscope exoscope surgery by Mao Sensei. So I would request, before we close, I have two announcements to make. One is we have this webinar every second and fourth Sunday at this similar time. So our next webinar will be on 14th of May. So I would request all of you to please kindly attend this webinar regularly and share the information with all your colleagues. So all those people can benefit from this education. One thing, at the end of July, that is 29 July to 2nd August, we have World Second YNS Congress, 4 days dedicated especially for the training, for the workshop, and for the presentation for young neurosurgeon. And it will be in Indonesia. It will be in person. So I would request all the young neurosurgeon to send the abstract to the secretariat, because we are just 2 months away and we are soon will be closing the abstract. So please try to attend, and this will be a wonderful conference for all of you, and it's a wonderful country to visit. So thank you very much. So before we close, I would request Professor Yoko Kato to say a final closing remark for all of us.
Before that, maybe this short, you want some make announcement about your congress?
Yeah, sure. So as a small announcement, but it was announced previously also. So on 15, 16, 17 September in our country, in Uzbekistan, Tashkent city, we are planning joint Congress of Central Asian neurosurgeons. That is called Silk Road Congress. It is joint with 7th Congress of Minimal Invasive Society of Neurosurgery, which is chaired by Professor Kato, both. So the Congress is going to be in a hybrid format, but in-person participation is very encouraged. So we all wait for your participation. There are links. We are with Dr. Ben and Dr. Sachin and Dr. Boon Seng Liev together as a Congress Secretariat, working together and working on the program of the Congress. There is already a website of the Congress where you can register yourself and send your abstracts. So it is already open. The web page is open, so you can register yourself and send your abstracts. And especially for young neurosurgeons, is very encouraged. There is a separate session for young neurosurgeons on the 3rd day, and there will be a workshop for endovascular and bypass surgeries, which is chaired by Professor Naoya Kuwayama also. So there will be expected many experts from different fields of neurosurgery we are just collecting their feedback answers, whether they participating in person or online. So, so this is ongoing process. We wait for your all active participation. Thank you.
Thank you very much. Maybe the Mao Sensei, maybe you can visit Tashkent after the board exam. Okay, September. If you can permit.
I will join. Yeah.
Watanabe Sensei. Yeah, thank you very much. So I think it's a great lectures from the very nice the talk. Even Dr. Abzur is not so feel well. We learned a lot. And also Mao Sensei, that even your age, I think it was a great lecture. I think. So you learned more and more from not only Watanabe Sensei, but also you should learn very basic thing is the microsurgical technique is very important. So my feeling is a bit different from under the endoscope and under the microscope. So that you are very lucky because you can train both under the trainer. Yes, under the leadership of Watanabe Sensei. So we had a very nice the webinar today. Thank you very much.
Thank you for your Professor Kato. Thank you.
Arigato.
Thank you very much. Arigato gozaimasu. Arigato.
Arigato.
ありがとうございます。
おやすみなさい。
おやすみなさい。
Thank you.
Sandra,
Thank you. Bye.
Bye bye.
Thank you. Thank you. Bye bye.
Thank you.
Bye bye.
Thank you.